Hello, everybody. Welcome to the ADAA educational webinar. The topic for today's webinar is helping teens and kids who have obsessive compulsive disorder. I'm your host and moderator for today's webinar. I'm Suma Chand. I'm an associate professor and a clinical psychologist specializing in cognitive behavioral therapy. I work in the Department of Psychiatry at the St. Louis University School of Medicine. I'm a member of the ADAA Public Education Committee, which produces this series of monthly webinars. Before we begin the presentation, I'd like to tell you something about the Anxiety and Depression Association of America, or ADAA. It was started in 1979, and today it is a leading nonprofit dedicated to increasing awareness and education about depression, anxiety disorders, obsessive compulsive disorder, post-traumatic stress disorder, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they're real, they're serious, and treatable. Please visit the ADAA website, that's www.adaa.org, which includes Find a Therapist, a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Now for some guidelines about the webinar. You can ask your questions at any time. Rather, you can type in your questions at any time. On your screen, you should see a chat panel with a little field at the bottom where you can type in a question and then hit your enter key, and the question will pop up. Other participants cannot see your questions. The questions are seen only by the presenter and the moderator. Now, some of your questions will be answered in the course of the presentation. So please type in your questions as soon as they occur to you so we can ask them through the course of the webinar. And others will be answered at the end of the presentation. Now, we'll try to get to as many questions as possible. If time gets limited, we may not have time to get to your individual questions, so we apologize in advance if that is the case. We are recording this webinar, so it will be available on the ADA website at a later date. Our presenter for today's webinar is Dr. Elspeth Bell. Dr. Bell is the director of the Bell Center for Anxiety and Depression. She's a licensed psychologist with training in cognitive behavioral therapy. She works primarily with adults and adolescents, focusing on the treatment of hoarding disorder, obsessive compulsive disorder, and related disorders. I will now hand it over to Dr. Bell. So over to you, Dr. Bell.
Okay, let's see if we can get it over to my screen. And here, let's go full slideshow. 1 second. And I'm not sure if individuals are able to see my, there we go. Oops, 1 second. One technical difficulty here. We will make sure that my screen is visible. Okay, is it now visible?
Yes, I can see it.
All right, awesome. There we go. So what we're going to be talking about today, just to get an overview of the topics I'm going to be trying to touch on, are figuring out the age-appropriate considerations when you're working with kids, with teenagers, because any kind of treatment intervention with OCD, there is a general approach that is empirically supported through research, but you want to modify it for the younger population, just because of being aware of developmental issues and also different life circumstances. So we're going to be going through some of those areas so that we can customize the so the CBT, the cognitive behavioral therapy, for these specific ages. And then we're going to be figuring out some strategies for how to do exposure and response prevention with these kids, because honestly, that's the fun part. And then we're going to look at different treatment interventions, different components that you might be more likely to consider when you're working with minors, individuals under 18, as compared to adults. There are a number of different groups that, or other people that we can pull into the treatment interventions. So as we're going forward, we take a look at the specific areas of OCD. I don't want to go into the specific descriptions just because of time, but when we're going through any kind of treatment intervention for addressing OCD, we're going to be paying attention to basically the words that are in the title. So we've got the obsessions. So how are we going to be addressing the intrusive thoughts that are arising within the individual? The compulsions, the specific behaviors, the rituals that, that the child, the teen, is engaging in. Now there's the compulsions, but then another part, which is not clearly identified in OCD, is the avoidances. So instead of going through a ritual, the individual might just avoid doing something altogether. So are there parts of life, are there types of activities that the person is not engaging in? Because with number 4 here, those particular activities are causing distress. So we experience distress with the obsessions that come up, that pop into your mind. There's distress with engaging in the compulsions because they're overwhelming, they're upsetting to have to do, but you have to do them. And then there's just someone might not be going out with friends. They might be staying home because they have got triggering thoughts about, if we go out with our friends, you know, if somebody's driving, what if I hit somebody while I'm driving? So I'm just not going to go out and socialize with my friends. So we want to figure out how to address each of these elements. Now with kids and teens, just as with adults, there are general themes that can occur, the ways that OCD might manifest themselves within an individual. So just to go through them quickly, there's the stereotypical, you know, the thought of contamination. So that would be the compulsive behaviors of washing, cleaning, somatic. So that's concerns about physical symptoms, you know, various, you know, almost like being a hypochondriac, what's going on with my body. Intrusive thoughts about harming, so that might be harming oneself, harming somebody else. The example that I love to use for that is if you're standing on a train platform or a subway platform, maybe having a thought that you could push somebody in front of the train. Sexual thoughts, this can be actually 2 different types of sexual thoughts. One could be wanting to have sexual contact with somebody else. That's often associated with maybe the idea of I could be a pedophile. And then there's also sexual thoughts, more sexual identity. That's sometimes referred to as HOCD. Could I be homosexual? Religious things, that might be having blasphemous thoughts, or I have to do something the right way, or God may injure or harm someone, relating over with that harming theme. Then we have doubt, and honestly, OCD is often referred to as the doubting disease. So with any of these areas, did I do something right? Did I do it thoroughly? Did I do it the right way, the way I'm supposed to do it? And then with the idea of exactness or symmetry, making sure that things are properly lined up. Again, that's often a stereotype associated with OCD. It is very present, but it is only one of the themes that we see with OCD. The compulsions, as I mentioned, the washing or cleaning, checking, going back to make sure that a door is locked, that the oven is turned off, that the light switch is turned off, but also checking. Is everything okay? I'm going to check in with you. Did you understand what I was saying? You know, Mommy, do you understand? I love you. I'm going to say that again. I'm repeating, but I'm also checking that everything is still okay with us. So repeating activities, needing to stand up, get out of the chair in the right way, because if there is a, quote, wrong thought going on, or you get out of the chair in the wrong way, something bad could happen. I once had a client who it was taking her almost 10 minutes to get out of the chair in my office, because if she stood up in the wrong way with putting her left foot down first, then something bad might happen to her mom. If she stood up the wrong way with the right foot first, then something bad might happen to her dad. And if she stood up with both feet, she wasn't quite sure, something bad, it didn't feel right, maybe it was going to be something happening to one of her parents, or maybe her brother could get injured. So she had the intrusive thoughts about harming somebody, the doubt about the right way to do something, and then the compulsion was repeatedly getting up and sitting back down again until she felt that she could do it the right way. So with all of these different issues, you're going to kind of see things maybe changing over time. The idea is that OCD can kind of ebb and flow. So somebody might start out with symptoms related more to somatic complaints that can then perhaps evolve into contamination, checking medically, wanting to go to the doctor, and then coming back. Then it might be excessive washing or cleaning relating to contamination, because contamination could maybe result in somatic complaints. It's very interesting how these can all interweave with one another. So as I said, you're going to see a lot of these same types of symptoms in teens and kids, just as you would see in adults. The big difference, though, with kids is that, one, they may not have the same level of insight that adults have into their OCD symptoms, recognizing that, wait a second, this is just how I've always done things, so I didn't think there was anything off or odd about it. Developmentally, you will often see with kids, like let's say, maybe 3, 4, 5 years old, certain behaviors that look like OCD. So my daughter's friend has to line up all of her dolls, all of her stuffed animals in just the right way on her bed, and she gets very upset if anybody moves them. So that would be under the idea of maybe ordering and arranging. But she's 4 years old, and developmentally, this is the age at which she's learning to control, manipulate her environment, be able to articulate how she wants things done or doesn't want things done. And she's also getting more into imaginative play. So she's creating a stage, interacting with her stuffed animals, and telling her mom and dad what they can or cannot do in that situation. So at this age, it's appropriate. But if this continues more into, say, around 7, 8, 9, a little bit older, jumping back here, number 4, that element of distress. Does this behavior become problematic? Does it get in the way of goals, what you're wanting to do with your day? And does it just make you feel bad that things have to be done in a specific way and I can't get away from doing them in that manner? So that's what we'd be looking for with kids. Another part for kids is the idea of this magical thinking. So there can be a bigger leap. If you think, most people have heard the rhyme, step on a crack, break your mother's back. Well, honestly, how does that happen? I could see step on your mother's back, break your mother's back, but where is this link between a crack in the sidewalk and injury actually happening to someone who could be miles and miles away? So that is a kind of typical rhyme that kids would get caught up in. So again, think of that as developmentally appropriate. But then when it starts to say, hey, maybe this could really happen, that's the scary part. That's when it becomes more of an OCD piece. So that magical piece, that not having as much insight into how something may be different, a behavior might be, it might be more of an OCD piece as opposed to a developmental piece, or is what I tend to talk about, more of a typical kid type of behavior. So when we're talking about interventions working with kids, this is what I generally put out when I first sit down with families. These are the different types of interventions that we would want to take into consideration, and then we'll go through how you kind of pick and choose what is going to be best suited for this particular child and for this particular circumstance. As I mentioned a little while ago, the empirically supported intervention of choice is really cognitive behavior therapy. I'm going to get into the specifics of what CBT is. What we do know is that this is the most effective way of creating lasting change in challenging somebody's OCD symptoms. But we also want to look at, is it appropriate to maybe look at the role of medication as well? And this really is based much more on how severe the OCD symptoms are. Sometimes it can be very difficult to engage in the cognitive behavior therapy because the OCD is so overwhelming. It can be paralyzing. So in circumstances like that, we would maybe look to more have the medication in place to help take the edge off of the anxiety, to help the child or the teen be more available to engage in the cognitive behavior therapy. We'd also want to be taking a look at how disruptive is the OCD in the child's day-to-day life. Is it interfering with their ability to attend school, to be able to participate in class, to do extracurricular activities? If that is happening, then yes, we want to make sure that a more immediate intervention to help the child be more available. So that's where we would look at medication. Other types of treatment, that would be elements such as family therapy. I'm going to be talking about that more towards the end. Family therapy is a key component because the child lives within a family, and we're all going to be working together to create a treatment team. So I'll talk about some other treatment elements that we want to take into consideration. I personally have a lot of fun with the treatment interventions. Kids, honestly, days are so much more stressful for kids. They've got their classes. A lot of the kids that I've been seeing are in advanced honors, GT, AP classes. They've got academic pressures. They've got multiple after-school activities. They're overwhelmed. And the last thing that they want to do is have the chore and the burden of having to go to therapy. My philosophy is that therapy is supposed to add to your life. It's supposed to enhance things. And with that, trying to incorporate some creativity and honestly just some straight out fun with doing some of the exposures. They're going to be painful and uncomfortable to do in the first place. Anything that we can do to help it be more engaging, you're going to get better treatment compliance, a higher rate of success, and they're going to actually maybe have fun coming into therapy. Comorbidity, we'd like to take a look at other issues that might be present. If there's maybe elements of Tourette's, ADHD, depression, other anxieties, so that way we can be having a multifaceted treatment intervention that's going to address all of these needs. I already mentioned the idea of normalizing behaviors. The idea of OCD, the compulsions, they're just behaviors. And honestly, they're behaviors that most people probably do at some point or another. It's looking at things on a continuum. So wanting for these kids to understand, and just really anybody struggling with OCD to understand that they're not, quote, broken. There's not something wrong with them. They're basically taking what people do day in and day out, but they're doing it to a greater extent. So people have intrusive thoughts. I think something like 97% of people acknowledge that they have had intrusive thoughts at some point in their life. However, what tends to happen is most people, their brains are not so sensitive to these thoughts. The thought comes into their head, yeah, I could push my mom in front of the train, I could do that, and the thought then floats out. Whereas someone who's got OCD, their brain is more like flypaper. The thought comes in and it sticks. And oh my gosh, I'm having this thought, so it must be something real. I must really want to do this. And then it snowballs. So putting it into context that people have these kinds of thoughts, and that's okay. What we're looking at is how do you respond to these thoughts. Again, with the behaviors, just about everybody washes their hands. That's just what we do. It's a question of how long do you wash your hands? How frequently do you wash your hands? And what is the goal of washing your hands? So, for me, my goal for washing my hands might be, well, I've got some marker on there and I'd like to just wash it off. Or I'm going to be cooking some chicken, or maybe I just prepared some chicken. And so I've got some of that chicken juice on my hands, and I'd like to remove it so that I'm reducing the idea of potential salmonella contamination. So what we look at is what are the range of behaviors, and then what are the thoughts that get paired with that. And so with that, from the idea of the developmental considerations, what are the magical thoughts? What are the assumptions that kids are making? What kind of connections are getting more and more reinforced as they do their compulsive behaviors and their avoidant behaviors more and more? And then figuring out how the two of you can sit down and really have a common language to discuss things. So if I'm talking with kids about the idea of exposures, and I'll just give it right now because it flows rather than in a couple of slides. If I'm talking to a kid about an extinction burst, I'm not going to sit there and quote the research about, how when you first start to challenge your OCD, you're going to experience an increased level in distress and anxiety. I'm going to say, hey, have you ever seen, now I know you never do this, but maybe you have a younger sibling, real pain at the grocery store. And your little brother says, Mommy, I want a candy bar. And Mom says, no. And that kid goes, but Mommy, I want a candy bar. And that kid starts throwing a temper tantrum and, basically like starts to have a meltdown. Mom goes, okay, here's the candy bar. And that quiets the OCD. That's, think about that little kid as OCD making demands. And then come back, that kid's going to say, next time I want that candy bar, start demanding it. The extinction burst is when Mom sticks to her guns. And she says, sorry, no, you can't have the candy bar. Now that kid might be throwing a tantrum, knocking down things left and right, kicking the cart, jumping up and down on the conveyor belt at the checkout. That's the extinction burst. The kid is saying, I'm going to make this so uncomfortable that you're going to give in to me. But Mom sticks to her guns, and she's just like, yep, nope, not happening. Eventually that kid's going to be like, oh, man, Mom's not giving in to me. And kind of quiet down. Same thing with OCD. So this is where I encourage, think about your OCD as if it was an obnoxious 3-year-old having a tantrum. Using that language, that's more engaging, that's more relatable for an 8-year-old who might be chuckling about, no, Mama, I never did that, but my little brother definitely does that, still does that today. And that also ties into the relationship building. That's that sense of connection, of being able to share ideas. I always present myself, I am not a superhero. I don't have any special, superpowers. I just happen to have a lot of training in how to work with OCD. And my goal is not to fix things. My goal is to train my client, train each kid in becoming an expert in their own OCD. And with that, we are working together. So one of my clients, we actually joke about, this is now, and she's actually graduated from college now. When we started working together in middle school, that's what we talked about. So I'm Dr. B, and she's Dr. H. And every once in a while, she still touches base with me, and she is still Dr. H, because she has a PhD in understanding her own OCD. And that's the team that we created together. So quick explanation about the cognitive behavioral model. We're looking at the interactions between thoughts, feelings, and behaviors. So the obsessions would be the thoughts, the compulsions would be the behaviors, and then the distress that's related to it, what makes it a disorder, is the collection of the uncomfortable feelings that come up. So with any treatment intervention, what we're doing is we're trying to tap into each of these areas. So we're trying to understand the patterns of the thoughts, how they influence the feelings, and how when you're feeling bad, you behave in a certain way. And then also how you engage in certain behaviors, that's going to be the treatment interventions, and that can bring up certain feelings or certain thoughts. So we're looking at tapping into each of these areas, basically in a progressive, not overwhelming, but in a methodical manner, working through each of these areas and building skills to change the behaviors, to tolerate uncomfortable feelings, and to either ignore or respond more appropriately to some of the intrusive thoughts that come in. And the way that we start doing that is we first assess for the OCD. This is the detective work. So figuring out, oh, sorry, don't know what happened there. Figuring out what are the intrusive thoughts. What are the rituals? What are the avoidances? So at the end of my first session, I say, here's your homework. I just want you to keep a log of anything and everything that's going on that could be OCD related. If it's too intense, because sometimes writing things down can actually be a trigger or an exposure with the OCD, then maybe leave me a voicemail message. Talk to your mom about it, or I'll make a checklist and you can just mark off the different things that come up. And I ask parents to do the same thing. I want parents to say, what do they see that's going on that could be OCD related? What are the behaviors that they see their child engaging in that they think can be OCD? And then also, what are they maybe doing to participate in the OCD? So how might they be accommodating their child? And some of it might just be, okay, fine, putting your shoes on, if that's too much of a trigger, yes, I will put your shoes on for you because we've got to get out, we've got to get to school. Well, that's accommodating the OCD. So if I understand how the parents are getting drawn into the OCD, that also helps with developing our treatment interventions. It also is really useful because sometimes parents will say, oh my gosh, I see my son, he's brushing his teeth twice a day. He brushes his teeth twice before we leave for school in the morning. So he wakes up and he brushes his teeth, and then he has breakfast and he brushes his teeth, and then sometimes I think he goes back and brushes his teeth again. So that's got to be an OCD thing. But then the kid might say, no, Mom, that's not OCD. There's a girl that I like, and the other friend said, man, I had onion breath one day, so I'm just brushing my teeth because I kind of want to impress this girl, and I don't want to breathe on her with onion breath. So that's an opportunity to educate everyone in the family, to really hone in on what are the OCD behaviors, and then what are more the typical kid behaviors. And then we kind of, from there, work with that OCD foundation. So as we do this, we're going to lay the framework for what is exposure and response prevention. We figure out what the OCD stuff is, and then we're going to build a hierarchy. Like I said, we want to move through things in a methodical method or methodical approach. So I liken it to climbing a ladder. Imagine that this ladder has 10 rungs, and each rung is one rating on your SUD scale, your subjective units of distress, where a 1 is, whatever, doesn't really bother me. And 10 is, oh my gosh, this is horrible. This is the most terrible thing ever. I can't handle it. So the goal is to get to the top of the ladder. And that's the most overwhelming and distressing pieces of the OCD. Well, how do you get to the top of the ladder? I always say you can back yourself up, take a running leap, and just kind of throw yourself at the ladder, hope that you're going to get up there, kind of scramble around a little bit, and you'll see kind of where you cling to it. You could try that, but that's not really going to be the most effective way to get to the top. Instead, what we would do is we'd start at rung 1. And from rung 1, all right, we're doing this, handling it, not really bothering me so much anymore. I'm going to climb up to rung 2 now. And so with each rung, the next level of challenge, it's only one step up. But it all adds up together that you end up getting to the top of that ladder. So that's how I encourage people to think about their OCD. Oh man, there's no way I could ever do those 10s. Those are just so overwhelming. Well, we talk about how to challenge that. How can you think about it as climbing a ladder rather than trying to do it all at once? I always say the best way to eat an elephant is one bite at a time. So here we are. Each week with our appointment, we're going to be taking 1 or 2 small bites out of the OCD until it's all taken care of. And this is what I do with talking about some of the language that I'll use. I'm a baseball fanatic, so I will liken it to spring training and practice rather than the game. So a lot of the homework that we're doing, that's the training, that's the planned challenges, that's doing the drills so that you learn how to manage your OCD. So that way, when you get faced with things in your day-to-day life, think about that like the baseball game itself, you don't know what's going to come your way. But if you've practiced your drills, you're able to handle those challenges a lot more effectively. Challenging the probability of something happening. A lot of OCD is tied into the absolute certainty that this is a horrible possible thing. Well, actually, but it's 99.9% likely that this could happen. OCD cannot live in the gray area. So it looks for those absolutes, the 0 or the 100. But we know there's no guarantees in life, death and taxes, that's it. So how can we say, well, what's the likelihood of, a plane crashing? Planes crash, we see it in the news. So that tends to exaggerate the likelihood of, oh yes, this is going to happen. But maybe we'll take a look at the statistics. How many planes are in the air during the day? And then what we would then look at is, statistically, how many times does this actually happen? So giving them a chance to reframe this situation. One example of a catastrophizing error would be, she was a middle school student, and she was overwhelmed, completely paralyzed about her math quiz. Because if she didn't do well enough on this math quiz, her life was over. And she would go through the chain of events. She wouldn't do well on the test, which means that she wouldn't do well on the exam at the end of the marking period, which means that she wouldn't get promoted up to the advanced math class next year, which means that she wouldn't be progressing in high school. That means that her applications to college would not be as competitive, which means that she wouldn't be getting a good job when she graduated from college. And if she's not going to a good college, getting a good job, then she's not going to end up networking with the right people, and so her life would be over. This girl was in 7th grade, and she was creating these huge questions. So that's where I tend to challenge. How would this actually happen? And are there double standards? So your friend who got the same grade as you on this quiz, how likely is that to happen? Kind of going back and forth. So challenging rather than confronting, asking open-ended questions. Could you explain this to me a little bit more? What's the likelihood, and what's a reasonable gamble, and what risk are you willing to take? So one of the numbers, is it, even if the chances are 1 in a gazillion, I'm not even sure how many zeros would be on that number. Would you be willing to take that chance? Some yes, some no. So that's what we're encouraging people to take a look at. So the goals of your exposure and response prevention is to just disrupt the compulsive behaviors, to reduce the checking, to reduce the reassurance seeking, and to do things in the wrong way. I use the example of showering a lot because we all shower, more or less, and we tend to do it the same way each day. That's more of a routine versus a ritual, something that has to be done in a specific way. So can we do it differently? Can we change it up? And if you catch yourself doing an exposure, can you go back and do it again? And re-challenge yourself. So that might be, oh, I touched something, I contaminated my hands, I went and washed my hands, so I'm going to go and recontaminate myself again. Or I straightened out my socks so they were even, so I'm going to make one of them just uneven enough, changing it up. And then what can we do during the course of each day to try and challenge ourselves? It might be intentionally stepping on those cracks as you're walking in. It might be walking in the door sideways, and kind of doing things that are going to intentionally create some kind of discomfort. So here are some of the fun exposures that I like to do. Hunting for contaminants. So sometimes with my clients, we would go and let's go look in the trash can, maybe touch the outside of the trash can, look for things that might look kind of dirty or gross. One thing where I used to work, you could never quite tell if something was there as a contaminant, as an exposure, or if it was just something's that might be a drop of blood on the floor. I'm not so sure. So we'd go and take a look at it and kind of get all close and maybe start touching it. Playing with knives, that sounds kind of scary, but it's a great exposure. If someone's afraid of it, we would line up the knives, create a hierarchy, and we would walk around with the knives, not running. We don't run with scissors, we don't run with knives, but we would sit there, and sometimes we just sit across from each other while the kid is sitting there holding a knife, pointing it at me, and engaging in some of those uncomfortable thoughts and fears. I could stab you with this knife. I could poke you with it, I could cut you with it, I could scrape you with it. I wonder what it would feel like. and just sitting with saying those thoughts out loud, becoming more comfortable with those thoughts, because recognizing that thoughts are just thoughts. They don't really have any power. They only have power if we let them have that power. I actually had a really cooperative family that had a lot of fun doing exposures with knives. So mom was allowed to, she covered herself with fake blood, so the daughter's holding the knife against her and it looks like she's actually cut her. This was one of her, almost her graduation exposures at the end of our work together. With Connect 4, that might be dropping in each chip. I could catch the flu, put the chip in. I could get a cold. Oh, maybe I could get Ebola. And putting in a chip, and each time you put a chip in, you say what could be happening. Candyland, when you land on a certain color square, it might be that that's a certain type of exposure that you do. Walking around the neighborhood, someone was afraid she would push people into traffic, so we walked around. I walked on the edge of the sidewalk next to the street, and she had her hand on my shoulder. And her exposure was to keep kind of pushing on my shoulder while she's listening to a recording of unsettling words as we walked around. Reading out loud. So that might be reading from a book, reading from a Bible if there's concern about religious themes of OCD, and maybe intentionally making some mistakes. The idea of tattooing, no, it's not real tattooing, but it's taking a Sharpie or a marker and writing some of the uncomfortable words on your body, so that way it's kind of there permanently, at least for like a couple of days, and then the exposure for the homework might be to go back and rewrite the words, and maybe writing it somewhere on the bottom of your foot so that someone else is less likely to see it. And then the idea of interior decoration is more putting up images and words that are unsettling. So someone was afraid of a car accident, so we would make little signs say boom, crash, dent, accident, and those we posted. And then we found photos. And what I say when I say we found photos, I did the searching for it, because you can't always tell if someone goes and let's look up Google Images and see what we can come up with. Oh my gosh, there's no real filter for or way to predict what photos might come up, so it might be more triggering and actually exacerbate the OCD rather than being a therapeutic intervention. So in those cases, I might either pull up the images myself, or then also the idea of having parents pull this up as well. So as I mentioned, some of these homework assignments, a loop CD. CDs are a little outdated, but you can get a number of apps where you could do just a recording of some of the trigger words. The app that I often use is, let me pull it up here really quick, it's called Voice Plus. And so some of these recordings, let me see if I can find one quickly. So let me play this into the phone quickly. Can't sleep. Stuck in bed. Hopeless. Sadness. Uncertain. So here we have a recording of her. It's about a 4-minute recording, and that's actually my voice repeating these words over and over again. And so she's sitting there listening to these words as part of her homework. And the idea is that it's to bring up the level of discomfort, and then you sit with it until your body just gets used to it. It's really hard to be anxious and bored at the same time. Someone had just asked if I can review the benefits, the advantages of Connect 4 or Battleship. It's more just a fun way of going back and forth with the exposures. So my client might say, I hope my mom stubs her toe and drops the chip in. And then I would say back, I hope my dad breaks his finger. And so it's a bantering back and forth, a little bit of a distraction. It helps you realize, hey, is anything really happening? And we're engaging with a type of exposure together. The app that I use for recording is Voice Plus, but really you can use any kind of just an app to record. And so then the next one here is a Write, Say, Think. So let's say if the intrusive thought is, my mom might die. So I would write, my mom might die. Then I would say it out loud. My mom might die. And then I would mentally think it in my head. My mom might die. And you go back through it. So what you're trying to do is engage as many of the senses as you can. So you're visually seeing it, you're got the motors creating it with your hand, and then you're got the auditory, and then you're actually creating the sound yourself. Flashcards would be putting the words or the images on flashcards and just sitting there and looking through them. You can also create a slideshow on your phone, with everybody being so tech savvy today. So that way, you know, it looks like the kid is more like flipping through something on their phone. Really what they're doing is they're looking at their trigger words and their images on their phone. Contaminating spray, let's say that somebody is fearful of maybe, let's say, fecal matter. What we might do is take a cotton ball, which is the one below, and maybe touch it to the toilet. Take the cotton ball, put it in a spray bottle, and fill that spray bottle up with water. Shake it up, and now that water is now toilet seat water. It's got the contaminant floor. And then we just kind of walk around the space and spray it on different parts of the house, different parts of the room, special items, and kind of just letting everything be contaminated. The challenge here is that we really want to have no safe space, because if there's a creation of a safe space, then that perpetuates the idea of there's something to be protected from, and there really isn't. And then visualizations would be, you know, writing a narrative, you know, kind of a story of, okay, I see myself walking down the steps to the metro platform, and a person is standing right next to me. I see what they're wearing, and I think I could push into them, and just kind of running a mental movie of what could happen. Now, one question here is, if there are multiple themes for someone's OCD, you'd be making separate hierarchies for each of those areas. But then you'd be addressing the areas all together. So maybe trying to see how you can get all the level ones for the hand washing and the checking and the harm thoughts. And then you move up to a level 2. The idea here is that you really want to be tackling all the areas of OCD. And some areas are going to be easier than others. But if you kind of leave some areas that are off limits, the concern is that they may kind of well up a bit more. That's my personal philosophy. Other people might say we focus on one theme, and then we move to the next, and then we move to the next. But I think it's really important to kind of have a comprehensive assessment about the different themes, how they're manifesting, and then actually I would even say sit down and talk with your client about how do we want to approach this. But what I found generally is addressing the various themes simultaneously, but doing it instead of one ladder at a time, one rung at a time on each ladder. I want to be mindful of time here, because I've got about just over 15 minutes, but I want to leave time for questions and answers. This is what I tend to do for the homework, and this is actually going to transition over into how we try to incorporate an overall treatment intervention. I'm a huge fan of a reinforcement system. So if you think about it, I don't go to work for free. You know, there's some benefit, there's some payoff for doing the work. And that's what we're asking our kids to do here. We're asking them to basically get a job challenging their OCD. So what we want to do is figure out how we're going to chart their progress. And the best way is to have something visual, something tangible. And I ask, depending on the age, ask the kids to keep track of it, ask the parents to keep track of it. And here, with the parents being involved, they're keeping track of it, so they're the scorekeeper, they're not the umpire. They are not saying, well, but you know, you weren't really wearing contaminated enough clothing this day. You were wearing something, but yeah, no, I'm not going to give you a check for doing that, because you should have worn more contaminated stuff. It's more just check it off. Did it happen? Yes or no? And then what we look at is, what's the level of success? We're not looking for 100%. You know, we're not angels. We're not perfect. And honestly, part of OCD is we're wanting to learn to be a little bit less perfect. It's, you know, adjust those standards a bit. So what we want to figure out is, what is this checklist? If we can aim for, start out with 50%, maybe not even 50% to start with. It might be starting out with just 25. But we want to see a continual improvement, as in greater success as we move on. And then we want to figure out how do we modify some of the target behaviors, our homework assignment, to address where the kid is at with their OCD at that time. So this is a chart that I might use, and I would actually be doing a new chart each week depending on the level of difficulty associated with each of the target behaviors and what else might be coming up. So it might be for the loop CD. That might be the homework assignment is to listen to it for 20 minutes a day. Wearing contaminated clothes, we would plan out what those contaminated clothes would be. Limiting the shower, and then being ready for school. And so this is not don't ritualize. This is not remove all behavioral avoidances. We're saying what are some of those smaller steps, and they will add up to challenging the OCD at large. So this is an example of something that we might be using. Because what we're trying to do is pay attention to the skill building. If you think about OCD, generally speaking, OCD tends to be managed. And that's my general philosophy is we want to learn how to manage the OCD so that it's not prominent, not so dominant. And what we would tend to look at then is how to have those behaviors fade to the background so they're not intrusive any longer. And that involves the emotional regulation, going back to the CBT model of the feelings component. And from there, learning to tolerate those uncomfortable feelings. Self-sufficiency is being able to manage things independently, perhaps rather than relying on other people to get engaged with things. The skill building for their social skills would be to kind of just be able to go out and engage with things, because sometimes the OCD kind of helps leave somebody feeling more disconnected from their peer group. Wanting to look at the motivation building, it's not fun to challenge your OCD. So why are they coming? You know, is it my mom is making me come here? And yeah, that's it. So what can they gain from the experience? And is there a level of enabling by other people? And how can we have those people, very often it's the parents, step back to reduce their level of engagement in with the OCD. So that way, maybe the kid does end up feeling a bit more discomfort related to the OCD. That can help build their motivation for wanting to challenge things. And then remembering that, you know, hey, we're all people, you know, so I don't walk around saying, you know, like, you know, I am not purely defined by being left-handed, or, you know, very rarely does someone say, hi, I am depression, or hi, I am dyslexia. You know, same thing, I'm not OCD. So OCD is one component of the challenges that a particular individual is dealing with. So we can also want to build up the other aspects of who this person is. Kid, adult, doesn't matter. We want to have things that are not focused on the OCD. So building non-OCD related activities, noting personal accomplishments, because so often there's just this focus on, we've got to challenge the OCD, we've got to focus on the OCD. Well, you know what? We're forgetting the rest of the kid. So, and some of that is also coaching the parents, and it's also with therapy, my looking at what's going on with you in general. So we want to kind of pay attention to that whole component, and then looking at alternative behaviors. So oops, wow, I did not mean to do that. Sorry. So when we're trying to do this, we want to see who all is involved with the OCD and who's then involved with the treatment. Some of the challenges, very often parents are involved, as we said, kind of engaging with the treatment interventions. So if we're talking about getting a spray bottle, an 8-year-old is not going to have ready access to a spray bottle and cotton balls. So the parents are going to be involved in some of that. Sometimes with siblings, because the OCD does have an impact on them, we want to make sure that they're not feeling marginalized. Oh, I don't have a disorder. I don't have a therapist. So, you know, what's going on with me here? So maybe having parallel behavioral reward plans for siblings so that everybody's kind of getting same level of attention, just in different areas. Sometimes friends or classmates are aware of what's going on. This is really up to the child, the teen, and the parents. Who do we tell? Who do we not tell? Sometimes it can be really important for teachers and coaches to be aware of what's going on because they may be doing accommodations. And we say, hey, we want to disrupt that. We want to remove that from the equation. Or we might be engaging the teachers and coaches saying, hey, we're going to be doing some kinds of exposures here just to let you know what's going on. And we may ask to have certain tools or resources available in the classroom to help with going through these exposures. There's been a couple of questions coming up in here related to dermatillomania, so basically skin picking or hair pulling. I'm not really touching on that here. Body-focused repetitive behaviors are related to obsessive compulsive disorder, but they're actually a separate diagnosis. And what we'd be using for that is more the COMB model, the combined behavioral model, which has elements of what I've talked on here, but it's not really focused in the same way. So I would recommend they're going to, they've rebranded their name, I can't think of it. It's the Trichotillomania Learning Center is what they used to be called, TLC. And so now it's more the TLC something or other for BFRBs. So that's where I would look to for the resources specifically for doing either hair pulling or skin picking or the nail biting. But it is kind of this foundation, but it does get customized specific to those interventions. BFRB.org. What we're trying to do with the parents and the clinicians here is reducing the reassurance seeking. So I don't know. Maybe that's okay. Maybe it's not okay. Yeah, you could maybe die if you ate that Hershey's Kiss off the floor. I don't know. You know, or is this, you know, so we're wanting to kind of say, you know what, we all live in that gray area. And some of this is educating the family about how they might be providing reassurance. No, there's nothing to worry about with the dark. Nothing bad will happen. Are you sure? Can you guarantee that nothing bad will happen? There could be a monster living under the bed there. Now, one in a gazillion billion, but it could maybe happen. And with this, you know, that's, you know, an example. My daughter's 4, so that's where we're at right now. But sometimes kids will just grill and grill and grill. Well, how do you know? And I think some of these kids would be awesome lawyers because they can find the loopholes in every comment, in every case that's being made. And so wanting to have something agreed upon as the family member saying, I love you, and because I love you, I'm choosing to not answer that question. Now, I'm not engaging with your OCD, I will engage with you. And just kind of reinforcing, I'm here to support you. And that supporting you means that we don't go into those behaviors. Supporting you means that I don't go get that extra roll of paper towels for you right now, because I'm helping you challenge the discomfort that you're experiencing right now. And so kind of having the family all be on the same page with a script to address those pieces. And then if there's non-compliance within the treatment, what's going on? You know, are the exposures, are they too intense? That can definitely be a possibility. So maybe we need to ratchet it back. I know I tend to get really gung-ho and enthusiastic about some of the exposures because I think they're fun, but they might be too overwhelming to start with. So let's bring it back. Increasing the support for doing the exposures. You know, I will, whatever exposure I ask a client to do, I am doing it right beside them. I'm willing to do it. I will not ask someone to do something that I'm not willing to do myself. So it may be coming up with us doing the exposures together in session, kind of like the training wheels, and then my stepping back, breaking it down into smaller pieces, and then also maybe assessing, are there secondary gains to perpetuating this OCD presence? You know, so could the family be benefiting? Could it be a distraction from other academic stressors or social interactions? Sometimes there's a big piece of, I feel like this is a sense of my identity. This is what makes me different and special. So I kind of want to keep it going. So we want to try to figure out what else might be going on there if it's interfering with progress for treatment. And then if we think about, hey, you've graduated from progress or from treatment here, well, there's a chance for relapse. And as I mentioned, looking at more the idea of managing rather than curing, I often liken it more to diabetes. So if you have type 2 diabetes, it is possible to reverse it through lifestyle changes, exercise, nutrition, maybe through medication, bringing it back down so you can, cease to have those symptoms of diabetes. But then we still want to be aware of, hey, if we start to see it creeping up again, being on the lookout so we can then intervene. Because basically all of the strategies for addressing one theme of OCD can be modified to address any other themes with OCD. So being able to take the skills and learn how to generalize with them. What can make somebody more vulnerable to experiencing OCD symptoms again? If they're feeling stressed, overwhelmed, that can, it creates a stress on anybody. So how does that happen? Sometimes it'll be more OCD symptoms flaring up again. Making sure that there's a clear understanding about the CBT model and what do we do if OCD seems to creep up again. So when do you reach out for services again? When might you develop your own exposures? How do you navigate? And just knowing that there are always resources out there for getting support. And it might just be a booster session. Just wanted to run this by you. How am I doing? That's great. Then let's move forward. So overall, figuring out, OCD is OCD, but every client is different. And making sure that whatever interventions you're doing, if you're working specifically with kids and with teens, that it's accessible to them. So you're not going to ask someone who's in kindergarten to be doing calculus. So let's focus on the kindergarten level math skills and build up from there. A collaborative work, and that's working with the kid, but then also working with the family and the school as is appropriate, and being mindful of the level of disclosure that would be going on. I personally think that creativity and humor are a huge part of asking someone to do something that's pretty uncomfortable and not so much fun. This makes it a bit more accessible. And then the idea of, as as a parent, as a therapist, wherever it might be, having consistency with the interventions, because OCD will find that loophole. And just like the mom at the grocery store, if she gives in and gives that kid that candy bar one time, it's going to be then reinforcing the, oh, well, maybe I should try for that candy bar again. But if you're consistent and you stick to your guns, then you're better able to see ongoing progress with challenging the OCD symptoms. So that's working with kids and teens with OCD in a nutshell. I wasn't sure if there were any further questions.
I think we may just have time for one question that is left. You've done a good job answering most of the questions in the course of your presentation. Somebody's asked about, what are your thoughts on parents or family members who perhaps don't meet the clinical level, but also exhibit some of the behaviors or thoughts?
So if this would be family members in addition to the child who's coming in, there is a strong familial component related to OCD and with anxiety disorders. So what I would do is kind of look at education as a whole. I would recommend having some kind of additional support for the family members, one for how they can be involved in the child's treatment interventions, and then through that kind of probing into the how does this come up with your own patterns and what you're seeing. So kind of through that education process, parents will often say, oh yeah, I kind of have a little bit of that myself as well. And so they then become more, perhaps more open to addressing their own OCD as they're seeing what their child is doing. And I've got to say, parents across the board will seek services and supports for their kids where they will not try to prioritize it for themselves. And in some ways, this kind of gives them permission to address their own OCD symptoms.
All right. I think we've come to the end of the webinar. Just 1 minute remaining. So some more information for all of you. ADA has started Triumph, its newsletter, which provides free e-news about resources, relevant events, and how ADA can help you. So do go to our website and sign up. We also have a support group for depression, so you can sign up for that as well. So thank you, Dr. Bell. That was a very interesting and informative webinar. Thank you all for attending this webinar, and we hope this was helpful. Please let others know about this series and consider making a contribution to ADAA. So thank you, everybody, for attending once again. Good night and take care. Bye-bye.
Good night.
Good night.